This is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and welcome back. If you've been with us earlier today, if you're brand new, tuning in now, welcome to our soiree, so to speak. I have with me on our virtual stage, Dr. Erica Bliss, formerly CEO of Q-Liance, currently a solo direct primary care practitioner with Equinox Care in Seattle. Also, Clint Flanagan, who is in Colorado. He started his direct primary care practice in 2009, and at the same time had a private fee-for-service practice that he maintained. He's currently in 70-plus locations across the U.S. Also with us is Brian Forrest, who is CEO of Access Healthcare Direct. He's been doing direct primary care practice for 20 years, and he started helping other practices to move to the DPC model in 2005. And I've had the great pleasure of meeting each of these people back, I think, at the first DPC summit that we held in 2013. And Clint, I think with you, I think it may have been the one in 2014 where we first met. So we've been colleagues for a long time, and I think of each of these as leaders in the direct primary care movement. And I want to thank you for taking the time to share your wisdom with us today. Clint, on to you.
Thanks, Larry, and I echo Erica's statements. It's just great to be on a panel with very familiar faces and friends and colleagues in this DPC movement that, you know, it's Brian and Erica look about the same, but I'm trying to grow my COVID beard here, and I've got this gray stuff showing up. So maybe DPC is aging on me in a different way than it ages on Brian or Erica or Larry in that case. But really appreciate this opportunity to talk about employers, direct primary care, and COVID and our response. And having been in fee-for-service primary care for around 20 years, now just thinking back, there was hardly ever a time where we would proactively go out to employer groups in our fee-for-service world. Almost always, you know, we were in our clinics working, seeing 25 to 35 patients a day, and just a rarity, right, to actually proactively reach out to employer groups. Sure, we had plans and still do with United, Anthem, Aetna, Cigna, and the big payers, and we were seeing employees, but rarely ever were we engaging in something besides seeing them medically in our office spaces, right? Contrast that with direct primary care. As Erica just mentioned, we are on the front lines and actively involved with our patients' lives, with employers, and doing what we can to help them. And really, in a time like this, right, a pandemic, who better to help guide them medically than your primary care physician? And again, not just a doctor, your doctor that you know and you trust and have a relationship with, right? Versus some of the other options out there. So, you know, I'm just thankful, actually, that we have direct primary care, and many of us in the movement, you know what we're able to do. We're agile. We can make things happen very quickly, as Erica mentioned. You know why? Because we'll just do it, right? We're physicians, we're family medicine docs, internists, primary care docs, and we're going to make it happen. And we're not restrained by the common things that we see in the fee-for-service insurance primary care system. So we're aggressive, and I like the comment I heard a while ago. You know, we're not cautious, we're courageous. And that's the last thing we need right now, is for there to be caution in the healthcare system. We need people to be courageous, and physicians, physician teams, and leadership on the physician side that's courageous as we're moving hopefully and closing a bit of a chapter in the fee-for-service world in primary care, and further opening this book that Brian and Erica and myself and others opened years ago. So I'd like to talk a bit about some specifics. You know, as Larry mentioned, we still own a fee-for-service practice, and we have a number of locations here in the Boulder County area. And then we have NextEra Healthcare. So it's given us these two lenses here that we've always compared and contrast. And COVID has really turned up that compare and contrast. For example, in our fee-for-service practice, we've probably seen at least 50, probably 75% decrease in our revenue, because fee-for-service is built on face-to-face visits. Those visits allow for a business transaction where you bill an insurance company and hopefully get payment 2 or 3 months later, right? There's really no telehealth in fee-for-service medicine. In fact, the payers have kind of bolted on telehealth, be it Amwell or Teladoc, onto these United and the Cigna plans, and created further challenges with connectivity and primary care physician and patient, because those services encourage you to reach out to a doctor you don't know for your urgent care issues, which, gosh, if I had an urgent issue come up, the last person I'd want to talk to is a doctor in a box that I don't know. I'd much rather talk to Dr. Brian or Dr. Erica, right? People that I know and trust, versus just some other person I don't know and trust and then have to pay $49 for. So as you look at the fee-for-service world, we in our practice were saying, well, for our employed doctors, they do get revenue from the fee-for-service lane and they get revenue from the Nextera lane. We were saying, my gosh, we're not going to have any sick care visits in our office, but we want to take care of our patients. So for the first time ever, it was kind of unique in that we said, gosh, we're going to stay open while other clinics are closing around us. Literally, a big system here in Colorado closed 21 clinics. We said, we're going to stay open and see patients. So what we did initially is said, we're going to charge a fee of around $75 per visit. And we were kind of wondering how patients in the fee-for-service world would react to that. Most of them were thankful that we were available. But again, here we are scrambling, saying, gosh, do we use our EMR for telehealth? Do we use Zoom? Do we use GoToMeeting? What do we do as a platform in our telehealth fee-for-service world? Because we're building that because we never really had it before. And so we built it and it worked okay. And then we got to a point where the payers, Medicare, Blue Cross, Cigna, Anthem, said, hey, maybe we'll pay for a visit. So here we were like, gosh, do we just continue to charge patients at point of service? That's working pretty well. Or do we now pivot and charge United, Anthem, Aetna, Cigna? So we opted to do that, and the conclusion's not out right now. I don't know how that's going to turn out for us, but again, it was a bit clunky, but we wanted to provide care. And truthfully, we're in the 21st century. Why can't you see your doctor virtually, right? Like, we do all kinds of other things virtually. We should be able to see our doctor virtually, follow up on our blood sugars, follow up on our blood pressures, text our doctor. But in the telehealth, in the fee-for-service world, it's not set up that way. The patient has to come into the bricks and mortar. And granted, we love that when they do come into the bricks and mortar, so we can establish that face-to-face visit. But there are many things we do in primary care, which is about half of what we do that can be done virtually. So for the first time ever, United, Anthem, Aetna, Cigna said, maybe we will pay practices, but of course, it comes with, you've got to go down the algorithm, you've got to pick the correct codes, you've got to bill correctly. And I'll tell you, that was a bit of a nightmare for our team that was very experienced in billing and coding. And in the end, we've set this stuff up and we actually don't know what we're going to get paid, if we're going to get paid anything. Much different than when the patients were paying $75 per telehealth visit. So let me contrast that with the direct primary care world or Nextera Healthcare. Patients were already used to our HIPAA secure telehealth platform that costs them $0 to connect with their doctor. And they had been using it for years, right? So we didn't have to introduce them to a new telehealth system. It was something they were used to. We did let them know that our office is open and we want to see you, but if it's sick concern, we'd prefer that we do that through telehealth. And most of them were understanding of that. And part of the reason is we want to keep our patients safe, but we also want to keep our doctors and our nurses safe. The last thing we want to do is have a doctor exposed and have to quarantine that doctor for 14 days. So we started that in very much the infancy of this whole pandemic, and we're doing that today. Today I saw patients in clinic. None of those patients were sick, but we took care of their needs. And it's funny because many of them were like, gosh, you guys are open? Even though we've messaged through our different social media platforms that we are open, because a lot of clinics around us are closed. So imagine if you're in this big system and your employer or you are paying your premium and your primary care clinic is closed during a pandemic. Like, what do, right? You turf to the urgent care, you go to the ER, or you don't get care. And that's unfortunately what we're seeing across the country, especially in rural areas. And so, I really feel for my fee-for-service private practice colleagues, because if you think of them, they maybe had 2 or 3 or 4 months of money in the bank to pay their MAs and their nurses and their doctors. And their revenue is built on that face-to-face transaction. And now they've seen 50 to 75% decrease in revenue. And groups like the Patient-Centered Primary Care Collaborative have said that 1 to 2 in 5 primary care practices will close or are closing, right? And that's really, really, really unfortunate. We already know that primary care is in high demand and low supply. And so the COVID pandemic is pushing these small private practices as well as big systems, as Erica mentioned, kind of to a place that, it's going to be painful and is painful already, but maybe it's as the dust settles, I think what's going to happen is this is going to be a catalyst to direct primary care. We not only think that, but we see that because A, we have doctors calling us wanting to be employed by us, leaving their jobs. We have doctors leaving their fee-for-service private practices after 20 years and starting their own DPC. We have systems, large healthcare systems that are saying, yep, we're finally going to do DPC now. So I really think, as many of us know, like Brian and Erica and Larry, that fee-for-service is just not made for primary care. And those that were kind of at the edge of the cliff prior to the pandemic, I think are going over the cliff on the fee-for-service side. And it's unfortunate, but I think it's a necessary that will hopefully get us to a point where we'll have more direct primary care, and then more solutions, maybe even besides direct primary care. But many of us doctors that created direct primary care, we know that this is a really good solution for physicians and also patients and also our communities. And what I mean by a good solution is it's a solution that really focuses on the care and the relationship, but also is affordable. I'd like to talk specifically about employer groups. We were concerned that we would see employer groups cut back on their direct primary care. And out of our thousands and thousands of members and many, many direct primary care employer groups in our NextEra system, one employer temporarily suspended their NextEra membership. And this is a company with 50 employees that takes people to the airport. So they're a shuttle service. And they temporarily suspended it because they're not taking people to the airport. So what we did, and we really felt was important, is we wanted there to be continuity. So we kind of put up a safety net. And for employers that are in that position, we said, gosh, let's, A, offer them a month or two of free care, B, offer them a discount on our per member per month. So definitely willing to say, hey, let's bend a little bit here so we can still take care of these people. We set programs in place that, we actually thought there'd be more employers taken care of, kind of like, let's call it temporary hardship because of finances going into their company. For example, restaurants that we take care of, but we really haven't had to enact it. And it's just, I think it's testimony to the value of direct primary care. Like even during times of struggle, when you have restaurants that have very little revenue compared to pre-COVID, they're still paying for their NextEra. They're still allowing DPC for their employees, which shows the value, because that those owners are looking at the line item and they're saying, what can we do to cut to help our company survive this pandemic? So we were bracing for more. And what I mean specifically is we thought there'd be more employer groups that would leave, but instead we actually saw a little bit of the opposite. We actually had employers coming on to direct primary care during this pandemic. We had employers reaching out to us saying, hey, listen, we hear that you have expertise in testing for COVID. Can you help my company? We had employers saying, a law firm of about 80 employees saying, we'd like our employees, and understand this law firm had a Cigna plan for their employees. But again, access to those primary care doctors is limited. So they said, hey, we'd really like you to handle the day-to-day details with COVID. So what we did in that case is we hooked them up with NextEra virtual COVID care so they can connect to a doctor 24/7 regarding their COVID concerns. There's a COVID screener built into the app that they can fill out if they have acute care concerns. And if they need to have some serology testing and or they need to have some PCR testing, our team, as we've received their insurance card and loaded that into our system, our team is able to get that arranged and do that in a seamless manner. Again, that's something that a fee-for-service doctor would have a hard time doing. and or, you know, how do you set that up? So in our case, we set it up in the classic DPC lane, a per employee per month cost, number one. And then number two, for some employers, we just charged a flat fee. So that's one way we've helped employers during this time. And those employers weren't, some of them not on NextEra prior to the pandemic. So our hope is that we show them that the level of service that we can provide in handling all of their concerns, testing, return to work, quarantine protocols with regards to coming into the workspace, almost working a bit like in the OpMed side of things. We've really said, hey, gosh, employers, we can help you here. Versus, you can imagine the CFO, sometimes legal internally and or CHRO trying to make these decisions, right? Who better to help guide these companies than doctors on the front lines that can really delineate between whether or not a person needs to have a PCR test versus IgM test, or whether or not the IgM test or IgG test is even worth it, right? So that's one thing we've seen in this time that has kind of opened up our eyes to, we can pivot a bit and help an employer group, and they don't necessarily need to have DPC full membership, right? They can have kind of DPC light. And by having DPC light, it'll get them a little bit more interested. With that, we've found that brokers and benefits advisors have reached out to us as well, because they're getting demand from their employers and they don't have solutions for them. And oftentimes you've got that benefit advisor or broker that's, let's say, has the great relationship with the employer, and they're trying to find some solutions. So that's a little bit about what we've done during this unique time. And again, those things are things that we never would have done in our fee-for-service world, really, right? We would have had the idea of how do we do it and or how do we charge for it, nor would we necessarily have had the time. When I used to see 30-some patients per day, when I was done at work, I would go home and take a break and see my kids, have some dinner, and then I'd work out a little bit, and then spend the last hour of my night coding and billing, not thinking about what can I do to help my community. And I guess what I'll say as I kind of close up here and let Brian talk a bit about what he's doing is, fortunately, with what we see, and this is more recent, because we've got some analysis that have come out of our relationships with employers, is we are saving these employers typically around $1,700 per employee per year. So when you compare a direct primary care plan, let's say a direct primary care PPO plan versus a versus a PPO plan without direct primary care, and you look at those two things within the same employer, and you look at those claims, all claims, ER visits, hospital stays, urgent care visits, outpatient stuff, and you compare those two buckets. So it's a pretty good comparison, right? Because you can almost have like an internal control, and you look at a full year at least. What we were finding in this particular claims analysis was with a school district of about 4,000 employees. We're saving that school district about $1,753 per employee per year. That's after they've paid NextEra. So we're giving a level of care, a level of connectivity, a level of, hey, what do you need, employer, during this pandemic? And for that, it's not actually costing the employer more money. It's costing them less money. You know, so we're super excited to talk more about that. And part of that will be at the Direct Primary Care Summit, the talk that Shane and I are doing. And this is on the heels a bit of the Milliman report that came out, right? That after 2 years of analysis shows what all of us DPCers know. Brian knows this, Erica knows this, I know it, that when you front a plan with direct primary care, you're going to see a way different level of care and access for your employees. And then B, you're going to likely see some cost savings. And even if you break even, who cares, right? Because you're getting better care. So I guess I'll leave it at that. And again, Larry, we appreciate the opportunity and look forward to hearing what Dr. Forrest has to say.
Great. Thank you very much, Clint.